Good.
Hear me in the back?
What?
All right, so the topic is how to call a code over the radio. So we've all been there, right? EMS calls you up and they're like, I've got a guy here, cardiac arrest, we've been doing CPR, no return of spontaneous circulation, I want to call the code. And what are you going to do? I mean, we want to make the right decision, and we want to know, are there any evidence-based guidelines to help us in doing that? And the thing is, if the person is not going to survive and they're going to transport them to the emergency department, do you really want to take the risk? Do you really want to have the risk of transportation, higher risk of biohazard exposure, and way more medical cost just to do an ED pronouncement? On the other hand, we don't want this to happen either, right? Coroner realizes corpse is living, breathing man. So we want to get it right. And let me just say up front, we're not talking about traumatic arrest. A trauma code, pulseless, apneic, we all know there's good evidence that these people are not going to survive, don't even start CPR. But when we're talking about a medical cardiac arrest, like, you know, guy clutches his chest and falls over, non-traumatic, those in the beginning of the code, very hard to tell who's going to live, who's going to die. However, after a period of resuscitation, then it all becomes more clear. And there are actually evidence-based criteria after you've done a period of resuscitation to help you decide who's going to be appropriate for termination of resuscitation. So you really have to first resuscitate a little while to prove futility. Now, the American Heart Association has published this algorithm. They call it the BLS, or Basic Life Support Termination of Resuscitation Protocol. And it basically says that if you ask these questions, was an unwitnessed arrest, not witnessed by EMS, no shocks were given, and there's no return of spontaneous circulation. If all of those criteria are true, then you can consider termination of resuscitation. If any of those criteria are missing, then you should continue resuscitation and transport, although there are some exceptions to that. So this study was the big study that validated the American Heart Association protocol. They did a retrospective review of 1,240 patients, and this was looking backwards. So they didn't actually apply the protocol, they just looked back. And they found that, how many was it? 776 of them were appropriate for termination of resuscitation. And of those, 4 of them actually did survive, 3 of which were discharged in decent neurologic condition. But basically, they came up with a positive predictive value of 99.5%. And that 0.05% that survived, well, you know, in the medical world, we use the 1% for medical futility. So it's below the accepted standard. And this protocol was considered to be A-OK to use. They found that the transport rate went from 100% down to 37. So there was like a 60-ish% reduction in the number of patients that were transported to the emergency department. So that's pretty good. And they actually talked a lot about this, like, is it ethical to use this termination of resuscitation protocol? And American Heart Association basically, you know, in their CPR guidelines, they said, yeah, it's going to reduce your transport rate by about 60%. It's going to decrease the risk of hazards to the patient, the provider, and the public from ambulance crashes. It's going to reduce risk of biohazard exposure, and it's going to save on those high emergency department pronouncement costs. More importantly, they said the quality of CPR just goes downhill. You can't do good CPR in the back of a moving ambulance. And the best cases for survival, best chances, are to do good, high-quality CPR on scene. Again, with a few exceptions that we'll talk about. So the same group, a few years later, then after the validation trial, they did this implementation trial where they actually applied the protocol. And they looked at a bunch of patients. They saw, what was it? They found 954 patients. And about half of them were transported. And they were TOR compliant. So they met, sorry, let me get that. Okay, right. About half of them were TOR compliant, about half of them weren't, but notice that 198 patients were transported even though the protocol said they should have been terminated on scene. So that means that there was about a 21% non-compliance rate. But importantly, note that of the 198 patients that were transported against the protocol, not one of them survived. Overall, they had about a 41% reduction in transportation of these patients. Now that's different. Remember the validation model, they said it's going to reduce transports by about 60%. Now in the real world, we're only reducing transport by about 40%. And the thought is, well, these kind of add up, the non-compliance rate and the transport rate, and that's what I call the discomfort with the protocol factor. So there's just some discretion that's being used, especially because these protocols are kind of new within the last 5 to 7 years. Okay, so this is the actual protocol that we use in Vermont. This is in our statewide EMS protocols. And it's basically the same thing. Arrest not witnessed, no return of spontaneous circulation after 20 minutes, no shocks delivered. If all of that's true, you call medical direction and you can consider termination of resuscitation. If any are missing, you're going to continue resuscitation and transport. And in general, you want to just basically continue your CPR on scene until you either get ROS, you meet criteria to terminate, or you meet criteria to transport. And let me just add, once you start transporting a patient, please don't call the codes in the back of the ambulance, okay? If you call the code, if EMS calls you up and like, yeah, we're halfway there, and we're still doing CPR, you now have a dead body in the back of the ambulance. That means the ED does not want to take them. They don't take dead bodies. The morgue isn't going to want them. You could be driving around for hours. You might decide, hey, I know, I will just take the person back and put them back in their recliner in their house. All right. True story, don't even get me started, okay? Keep doing CPR until you get to the ED. Here's a pretty straightforward case. 68-year-old male, he had found cardiac arrest at home by family, not witnessed by EMS, 20 minutes of CPR, got a few rounds of epi, they call you up and they want to terminate. What do you think? It's pretty straightforward, meets all the criteria. Medical direction when it said okay to terminate this case. But it's not always so black and white. And I'm showing you these protocols, but I'm telling you they're advisory, okay? It's not a cookbook that you just follow. This was an 83-year-old male. He had sudden chest pain and collapse as witnessed by his family. They started bystander CPR. There were no pulse, no respirations. EMS arrived and applied the AED and gave 2 shocks. But then they did more CPR and they sat there for another 20 minutes and they got 5 no shock indicated messages. And at that point, although they could have just, because they got the 2 shocks, right, they could have just packed them up and transported, but they didn't. They called up medical direction and they said, this is what we got. What do you want to do? And they said, by the way, he has hypertension, diabetes, Parkinson's, and COPD. Transport or terminate? Well, in this case, medical direction chose to terminate the case. But, so I'm saying it's not always black and white. But what if this same patient had been 38 years old instead of 83? And that, they probably would have, after 2 shocks, just packed him up and transported him. not even called you. But you might get that phone call and say, yeah, I'd like you to bring him in. In general, if a shock is given to the patient, EMS is told to transport as soon as one of these things occurs. They've given 5 shocks. They've got 5 no shock indicated messages. That's going to be about 20 minutes. Or, of course, they get RUPS. Okay, a couple of the exceptions. So patient with narrow complex PEA and a rate greater than 40, those are patients that you probably do want to transport. And your basic EMS folks are not going to be able to tell you about this. This is a rhythm interpretation, so it's going to be a paramedic making this call. But if they call you up and they say they have a narrow complex PEA over 40, you may want to transport them, because these folks, there have been multiple case reports of these patients surviving neurologically intact even after an hour of CPR. And the thing with narrow complex PEA is that it's usually some sort of RV mechanical problem that's amenable to being fixed with either fluids, pericardiocentesis, needle decompression, thrombolytics. Peter will put the ultrasound on and get it all figured out as soon as they roll through the door. The other ones that you want to transport are the refractory VFib or VTAC. Your wide, slow PEAs, though, after 20 minutes of CPR, that's a sign of a sick heart. That is probably going to be a heart that has global myocardial dysfunction, acidosis, hyperkalemia, ischemia. Very unlikely that this rhythm is going to be recoverable after 20 minutes of CPR. And that'd be a good candidate for termination. Also, end-tidal CO2 less than 10 has been associated after 20 minutes of CPR with a 100% fatality rate. And it's a good tool to use. If your end-tidal is really low, they're not going to come back. But note, if all of a sudden it pops up to a better range, that might be a sign that you actually got RUPS. All right, so here's a 56-year-old male. He had, oh yeah, this guy dropped his kid off at school, and then they think about a half hour after school started, they found him in the parking lot. The school nurse ran out with the AED and got put it on, but there were no shocks advised. EMS arrived. Based on the school schedule, they're pretty sure he was laying there for half an hour, unless the kid was late for school, I guess. And EMS came and they did IO, they intubated him, they gave a bunch of epi, they put on the end-tidal CO2 and it was 6. They called medical direction. What would you do? So he was terminated. It's like we tried everything, low end-tidal CO2, pretty long downtime, went ahead and terminated him. All right, so this is a study, homegrown. This is District 3, Vermont EMS, Chittenden County. We got it published in Resuscitation, so that's pretty cool. And it was another implementation trial of the American Heart Association BLS protocol. We actually had a pre-protocol group and a post group, pre and post. So before here, we transported almost everybody. Then we implemented the protocol, and we had 2 years on each side. And both groups, the characteristics were similar. No difference between the groups. In the pre-group, we transported about 91% of patients. And in the post-protocol group, we got it down to about 70%. So we had about a 22% reduction in the transport rate. Now, what's up with that? Remember the validation model, they said you're going to reduce your transport by 60%. And then in that other implementation model, they reduced it by 40%. And we're way down here at 20%. So we think we could do better. But what do you think were the reasons for non-compliance with the termination protocol? Top 3 reasons. Number 1, medical direction. I'm not comfortable with that, bring them in, okay? Because it's a new thing. Family request, we're not comfortable with that, bring them in. And public location, it's in the middle of the baseball field. everybody's uncomfortable with, so we bring them in. Okay? We had about a 33% non-compliance rate with the protocol. We feel like that's okay. As we get more comfortable with it, it's going to get better. But note that medical direction was responsible for 27% of those. So just to build your comfort level a little bit when you get these phone calls, let's drill down on those numbers a little bit. Notice that of the 44 patients that met TOR criteria and were not transported, okay, so 44 patients met criteria, were not transported. All of them died. Okay, not one of them woke up the next day in the morgue. Okay, and of the 22 patients that were transported against protocol, so the protocol said you can terminate them, they got brought in anyway, none of them survived. Not one of them survived. So we didn't have the 4 survivors like in that first thing. We think with the as we implement this with good sense and EMS, medical direction, and EMS provider thinking things through, we're pretty much doing a pretty good job with these, implementing these protocols. Last case, this was a lady at the campground on North Beach in Burlington. She was only 35 years old and had sudden cardiac arrest. The lifeguard ran over with the AED from the lifeguard station and actually got a shock. And then EMS arrived and they got a bunch more shocks. They put in a King Airway, they got an IV in, they gave epi, and they actually shocked her 9 times and transported to the ED. Upon arrival in the emergency department, we did, went crazy, intubation, magnesium, Lido, threw in a little amiodarone for good measure. 12 more shocks, and we got ROSC. And you know what? She went home neurologically intact 2 days later, totally better. In the end, they did a cath that was clean. In the end, they said a little puppy died. It was broken heart syndrome, Takotsubo. So anyway, that's the protocol. Learn it, use it wisely, and I'll take any questions. Questions? All right.
Clouser. I am actually one of your friendly neighborhood intensivists. I'm not an ER physician, but I do like to come hang out with my friends in the ER. Is it on? Okay. Can you hear me now? Yes. All right, great. Megan and Kyle, are you listening? Can you just tweet out #Clouser sucks at PowerPoint?
Yes.
Clouser can't find the answers on my
I think I accidentally turned it off in my defense. Anywho.
The later.
Thanks again for having me here. I was asked to come give a brief update on early goal-directed therapy. Hopefully no one's rolling their eyes, falling out of their chairs in disgust or boredom. We all deal with sepsis and the resuscitation of patients with sepsis on a daily basis. So it is good to talk to our ER colleagues and be on the same page with how we're managing these patients. Is there a whole lot of new stuff in early goal-directed therapy? Well, it depends what your perspective is on. So let's just kind of go over a few things and we'll see what we come up with. So other than my lack of PowerPoint skills, I don't have anything too out of the ordinary to disclose. I have no financial stakes in any goal-directed therapy or IV fluids or antibiotics. But what I'd like to kind of go over in the next 18, 19 minutes are really just to describe what is the underlying physiologic point to doing early goal-directed therapy, talk about some of the findings and limitations of the original early goal-directed therapy study from back in 2001, and try to summarize in a clear, concise way what is the most current up-to-date evidence-based strategy to manage a patient who presents to my ICU or your ER with severe sepsis or septic shock, which I should actually say is sepsis or septic shock, because in our growing landscape. We're changing definitions constantly. We don't even know how to define it anymore. So this paper was published in 2001 New England Journal by Manny Rivers. You're all very familiar with this. This was the trial that launched the whole kind of concept of rapid resuscitation of a patient who shows up that's sick with sepsis. And the point was, Manny really just looked at it as a patient sick and shock with basically impaired oxygen delivery. As their blood pressure falls, cardiac output may fall, tissues are starving for oxygen. So because of that, the longer your organs go without adequate oxygen delivery, perfusion, the more organs start failing. And I think everyone knows the more organ systems that go down, the higher your risk is to die, not survive your episode of sepsis. So the concept was, well, if we just rapidly restore organ perfusion and optimize oxygen delivery, we should therefore decrease the risk of organs failing and improve survival. So the strategy they used to do this was really to just target the hemodynamic endpoints that we can target at the bedside. Simple things like mean arterial pressure. So in this case, we shot for a MAP of 65 or greater. Looking at urine output, making sure the patient's making at least a half a cc of urine per kilo per hour. Then getting into crazy stuff like central venous pressures. Now, ICU doctors don't talk about central venous pressures anymore, but this is 2001, so we're going to go with it for a few minutes. So they really tried to optimize preload by determining, by basically making the assumption that if we can get a CVP up to the 8 to 12 range, we should be optimizing preload and optimizing our hemodynamics. And then in the final piece of that was, in order to deliver oxygen, you have to have oxygen carrying capacity. So they would transfuse patients with blood to keep their hematocrits over 30%. Now, this was a single center study in Detroit, Michigan of 260 patients. 130 got early goal-directed therapy, 130 got standard therapy, and they found a tremendous reduction in mortality by giving early resuscitation for sepsis, 30% versus 46%. So, I don't know, intensivists are easily tricked, I guess, and bamboozled. We do this all the time in critical care. You may not read our literature, but we do things for a couple years, then it gets disproven a couple years later, and then we stop doing it. It goes back and forth like steroids. Gee, my God. Steroids are still kind of in, but not really. Anyway, so the emphasis after the early goal-directed therapy was that we should be doing this for everyone. It got incorporated into the Surviving Sepsis campaign and really became one of the hallmarks of what we did for patients within the first 6 hours of sepsis and septic shock. So the big question was, which part of this bundle of care with early goal-directed therapy actually made a difference? Was it targeting a MAP of 65 with vasopressors as needed? Was it pounding the patient with fluids to get the CVP up to a magical number of 8 to 12? Was it giving a blood transfusion? Despite the fact that nowhere else in the critical care literature does giving patients blood actually show any benefit unless you're bleeding to death? Or is it magical central venous oxygen saturation that by targeting 70%, is that what makes a difference? So finally, as of maybe about 3 years ago, we answered a lot of these questions, and probably all of you are very familiar with these studies, the PROMISE trial, PROCESS trial, and the ARISE trial, all sought out to answer these very specific questions. And spoiler alert, basically found that comparing basically the Rivers protocol, or early goal-directed therapy versus usual care, in modern day, 2014 or 15, they found no difference in mortality. The mortality rate was 18 versus 18 in the ARISE trial, which was done in Australia. The PROCESS trial, which is a big multi-center, huge trial done in the United States, a little bit different than ARISE or PROMISE. They actually had early goal-directed therapy versus a protocolized based care model, which was basically a little bit slightly modified version of early goal-directed therapy versus usual care. Again, they found no difference in mortality. Then the PROMISE trial, which was a big multi-center study done in England, which again found no difference in mortality. So this basically showed that today our modern day early goal-directed therapy, whatever you want to call it in the ER, of early recognition, antibiotics, some amount of fluids repressors is just as good as targeting CVPs, central venous sats, giving patients blood, putting in central lines. None of that seems to really matter. And to drill down into that a little bit more in detail, if you look at the process trial, for example, when they broke it down into groups, I don't know if you can read that in the back, they had over 400 patients per group. If you look at the total amount of fluids they received, it's about 2.8 versus 3 versus 2.3 liters of fluid, and roughly the first 6 hours of resuscitation. They put in way more central lines in the early goal-directed therapy group. The amount of pressors was relatively unchanged. There was a lot more dobutamine and blood transfusion use in the early goal-directed therapy group. But again, no difference in mortality using what we would consider our modern day resuscitation skills compared to what we used to do back in the olden days. And similar findings here, if you look at the ARISE trial in Australia, this was 800 patients per group. Just to key in on the amount of fluids these patients received, we're looking at less than 2 liters in the first 6 hours. No patients ever had central venous sats measured at all in the usual care group. They had very low use of dobutamine in the usual care group and very little blood. And again, no difference in mortality. And then in the PROMISE trial, the big study done in England, again, very low amounts of fluid, 1.5 versus 1.7 liters of fluid. Almost half as many central lines were placed in the usual care group, and a little less vasopressors and very low utilization of blood and inotropes. And again, found no difference in mortality. So I think what this highlights is that all those fancy things we used to do are not necessary anymore. It really boils down to early recognition, aggressive initiation of antibiotics, and some moderate degree of fluid resuscitation. How many people here believe in 30 cc's per kilo for sepsis? Oh, I love you all. A couple? All right. Well, so this is kind of the thing. Right now, the Surviving Sepsis campaign recommends that we are giving 30 cc's per kilo of IV crystalloid for patients who present with septic shock within the first 3 hours of resuscitation, or presentation with septic shock. This is a strong recommendation with a low quality of evidence, and I think the key is every patient that comes into your ER with sepsis or my ICU with sepsis, they don't all have pure septic shock. There's always, or very commonly, an overlap of hypovolemia, so you have to be able to fill the tank, make sure they're resuscitated if they're hypovolemic. But after that, we really want to focus on being thoughtful and careful about our fluid administration, because after you folks get them kind of resuscitated and bring them up to my ICU, we now know with the growing body of evidence that the more fluid overloaded patients get over the first several days of their ICU course, the higher their mortality. This graph here kind of depicts 4 different quartiles of degrees of volume overload, showing that the patients in the highest quartile of fluid overload by day 3 have the highest mortality. So what we're trying to do is give not too little fluids or too much fluids, but the Goldilocks amount of fluids, just right. And that's where things like using your point-of-care ultrasound or some other dynamic markers of fluid resuscitation or fluid responsiveness is probably very helpful for our patients. So this is kind of a new paper that came out in the last year looking at the effect of early resuscitation protocols on patients with sepsis and hypotension. This is a randomized controlled trial actually that took place in Zimbabwe. Kind of along the same lines as the FACEP trial, which was done a couple years ago in Africa on children, which basically showed that patients, at least pediatric patients that were given lots of crystalloid for resuscitation and sepsis had worse outcomes. This trial actually showed similar findings in adult patients. Most of these were men, many of which had HIV in resource-poor settings in Zimbabwe. What they did was basically sepsis protocol versus usual care. You can see that the patients in the sepsis protocol got more fluids by about 1.5 liters in the first 6 hours. They don't have vasopressors on hand very much. They did have dopamine, so about 14% of those patients received dopamine for low MAPS versus about 2% in the usual care group. They didn't really have any statistically significant difference in the amount of blood, and the time to antibiotics was about a half hour slower in the sepsis protocol group, which I think is interesting. But basically what they found was that the patients who were in the usual care group actually did better and had a lower risk of mortality. And what may be happening is that in resource-poor settings, as you're aggressively fluid resuscitating these patients and their risk of acute respiratory failure rises, they don't have ventilators like we do. So they found that because of increasing risk of respiratory failure in patients who had aggressive sepsis protocol utilization, they had higher mortality rates. So if any of you are in super resource-poor ER working by yourself at night with maybe one nurse, your ventilator's back in the corner for 1993, and you're nervous that they're gonna have to be intubated if you give them lots of fluid, just don't give the fluid. That's cool. Just use pressors, give them antibiotics. I think you're probably helping the patient in the long run. I think Peter might like this. This is a systematic review and meta-analysis of incorporation of dynamic assessment of fluid responsiveness into goal-directed therapy for sepsis. Basically what they did was look at a bunch of different types of ways to assess for volume responsiveness. So in the ICU, we would use things like stroke volume or pulse pressure variation. We can do variations on themes of passive leg raising, and we can look at things like end-tidal CO2 rise, or we can even measure aortic flow velocity and look for respiratory variation. All we're trying to do with dynamic parameters or dynamic markers of fluid resuscitation is to see into the future and kind of predict who's going to respond to the fluid bolus before we give it. And what this basically means is, so for example, on this slide, I use a passive leg raise as an example. So if you would do point-of-care ultrasound and measure the patient's aortic flow velocity and see a lot of respiratory variation in the flow, in the velocities, you could do a passive leg raise and repeat that test and see if the variability goes away. It's very similar to stroke volume or pulse pressure variation. It's a way to see that if we give a patient basically an auto bolus of venous blood from their legs by raising them in the air and see a decrease in the amount of respiratory variation, that should predict that they would be responsive to an actual fluid challenge. Now, I will tell you that measuring aortic flow velocity is not exactly easy. It's tricky to do. You have to be able to get a 5-chamber view of the heart and an apical view window, but it's just an example, a proof of concept. In this study here, the systematic review, they looked at 12 different studies looking at various forms of dynamic markers and found they all favor decreased mortality by using them. So I guess the bottom line with this is that if you think the patient's hypovolemic and you've given your first few liters of fluid, start thinking about ways to test for fluid responsiveness before you go giving your next third and fourth liter, because ultimately those third, fourth liters may be doing harm. And all the new sepsis resuscitation protocols that have been published in the last few years, they're really not going much over 2 liters, which still is probably only 20 cc's per kilo for a lot of our patients who are into Ben and Jerry's. Anyone here work in New York? Okay, so you probably read this paper. It was published this year, actually it was last year in the New England Journal, May 2017, looking at time to treatment and mortality for emergency management of sepsis. Basically the concept was they took the ER databases of all sepsis patients from New York State and looked at compliance with a 3-hour sepsis bundle, which was basically getting blood cultures, giving antibiotics, and what was the third thing? Sorry, blanking. Antibiotics, cultures, and can't remember. What was it?
Fluid and hypertension.
Thank you. Fluids. And basically they found that the longer time there was to depletion of the bundle, the higher the mortality. But interestingly, they found that even if you delayed time to administration of fluids beyond that 3 hours, there was no difference in mortality. So kind of proves the point that maybe it's not about the fluids, it's about the antibiotics, it's about the recognition, it's about maintaining that blood pressure in your MAP making sure the patient's perfused, checking back on them. There's probably some degree of thinking about lactate clearance as a marker that you're doing the right thing for resuscitation. So again, the fluids I think we need to dial back on and focus on the basic stuff. So what does modern day early goal-directed therapy look like?